I want to tell you a little bit about ECCO and how it evolved. In fact, we were, someone remembers here Tim Lenartowicz? Tim Lenartowicz, he used to be at the ministry, then he was a student first, then worked at the ministry, and then came to work at RNAO. And we were at a conference, and in the break, Tim says, "How is it going? Do you like it? How is it going?" I take a napkin and I said, "Look, Tim, the system is," I don't want to say the word I use, "we need to turn it upside down. Here is what needs to happen. We need to strengthen community care, we need to do this, we need to do that, needs to be anchored in primary care." And Tim says, "Can I have that napkin?" And I said, "Yes, and if you write it up, we will make a report out of it. Let's work on it." That's how ECCO 1.0 came to be. Why? And I'm not going to ask you to go to the mic because if not, no more prizes will be left. Why did we do ECCO 2.0? So ECCO 1.0 was presented to Minister Deb Matthews in closed doors. And actually what I said to the minister at the time, she and one of her staff, is if you make it happen, you ain't going to see ever another ECCO. And we will not say we did it, we will say you did it, because the system is not in good shape, needs to be turned upside down. And we did say to her, we are going to wait for 6 months. And if in 6 months we don't see much, we will make it public. That report, by the way, ECCO 1.0, received endorsement, actually no, the 2.0 of every single party. I think one of you spoke yesterday about Christine Elliott that was in opposition, and she actually endorsed it, and also did, I believe was Francelina maybe, at the time. Every single party, Mike Schreiner was not yet elected, so, and used to complain, "When are you going to have me also participate?" And I used to say, "Get a seat, get a seat, get a seat, we need you there." So ECCO 2.0 was developed in 2014, as Janet Hunt said, because nothing happened between ECCO 1.0 and 2.0. ECCO 2.0, the minister, who was the minister then? No? And he spoke, actually. No? That's interesting. So ECCO 2.0, 2014, didn't happen right away. What I am going to say was when Eric Hosking was in the opposition, was after 2014, check it out for me. He actually took ECCO 2.0 and he made it part of putting patients first, or something like that was his initiative. And he referenced and he referred to it. And then we said at RNAO, we are making headways. We are going to move to more community care. Did it happen? No, it didn't happen enough. So then in 2018-19, we started to work on ECCO 3.0, because we had it, like we had it, right? They had said they will use it for this, for that, for the other. Nothing had happened much. And at the time, and our colleagues will speak more about that, indeed, there was also discussions already that in 2020, something will happen and they will start system transformation, and the rumor of OHTs was there, et cetera, et cetera, et cetera. And some of us were called to a closed doors meeting. I don't know if Marian or Matt were with me in that meeting, looking at what the OHTs will look like. And at the beginning, primary care was not even there. And she was from the community health centers, the executive director, and myself all was dismayed. Christine Elliott was there, and we said, how is it possible that we are going to have strengthened community care and primary care is not part of this initiative you're talking, they did put primary care. And we thought, in good faith, that primary care will become the anchoring of the system as RNAO, and any country with a good system always has thought, and some of them act on that. What happened then is that despite that they put the OHTs out and that primary care was supposed to be a very big feature. In fact, some of you may remember that Christine Elliott didn't even want to do any announcement of OHTs in hospitals. She said no. So we did one in a garage of a place where paramedics were there with nurses, and some of us were there. She did many of them in community health centers, et cetera, et cetera, et cetera. What happened then? What big event happened in this province, well, in this country, in the world? COVID. So by design or by fault, when difficult times happen in the healthcare system, countries, if they don't have a strong primary care system that is anchored there already, everything, retrench to the usual, to the safe. And if they have also a big lobby group, which is the hospital sector, they retrench even more. And if they want to protect the budgets of a sector, and that's never primary care, unfortunately, nor is home care, then who do they protect? The hospitals. So you will hear a lot more about what happened during the pandemic, that really will retrench all the way to hospital care. You may remember the vaccinations, instead of in public health, were done in hospitals, by hospitals, not by public health units. That always had been the case. We offer that home care nurses bring the vaccinations to the homes of people for those that didn't happen, et cetera, et cetera, et cetera, et cetera. So when we deliver ECCO 3.0 in 2020, right, we basically COVID-sized. It was already in the works. In fact, we were going to release it before the pandemic. We COVID-sized the report to bring the picture of what was happening during the pandemic. And in ECCO 3.0, for the first time, we put long-term care as part of community care. Why? How they're called? They're called nursing homes. Well, they're called nursing homes, but they're these mega entities, right, that do nothing, that it looks like a home. And we said that long-term care and nursing homes needed to be designed and needed to be conceptualized as part of community care and the homes of people. And that's the new piece completely in ECCO 3.0, in addition to make public health what public health always is, and don't shove them on the side when there is pandemics, etc., or whatever. And then the time came that we need to look at what's next. What progress have we made? What progress have we not made? What are the possibilities? What are the strengths? What are the dangers? So what's possible in one side, and what's, right, the sun and the storm, if we go in the wrong direction with ECCO 4.0, but more importantly, with the design of the healthcare system. That is what's critical in ECCO 4.0. And in ECCO 4.0, the key new foundations that we bring, in addition to still enhance community care, because ECCO stands, that's for the students, enhancing community care in Ontario, right? So anchor the system in primary care, that still always will remain with ECCO. Make home care stronger, that's very important for community care. Design long-term care in the context of community services, in the context of enhancing community care and not a la hospital type. Not that hospitals are not good, but hospitals should be used for what they are, and they're not for primary care, or ought not to be unless it's a very small community, where you can make models like that. And then we also say in ECCO 4.0, make EDI, equity, diversity, and inclusivity, and make social determinants of health. And if we had the power, we also would say environmental determinants of health, and we speak about that, but not enough in ECCO. But yes, in our platform, and not enough because we don't value it, but because we don't think the system will understand it well. Make that the foundation for the health system going forward, because if not, instead of reaching the sun through primary care, even if you had primary care, even if we had strong primary care, if we don't make social determinants and EDI, which in a way goes side by side, we would end up in a storm anyways, not in the sun. So that's the story of ECCO. Expect that there will be more in the future. I will come back after our colleagues speak, and each one of them maybe will have a question for you, and then first come, first take the prize. Okay, thank you very much, Matt. All yours.
Thank you, Doris. Good morning, everyone. Good morning. Thank you, Paul Andre. Yeah, thanks for the introduction, Doris. Let me see if I can operate this machine. Yes, so I want to begin with an orientation to ECCO beyond the broad historical sweep that Doris has provided for you. We as policy people, we believe in ideals. They orient us, they set us off in a certain direction, but as policy people, we understand that the real world gets in the way. What we hope for is an approximation that's actually better than Kelway using the draw function on PowerPoint, but we get closer to the ideal and get as close to the ideal as possible. And this is the way I like to think about the ECCO model, that it is an ideal, and our job as policy people is to try and ground that ideal in real time and real space. Space keeps shifting, time keeps ticking, things change. So every once in a while, new considerations about how to fit this model, how to enhance community care and ground it in primary care in the real world are required. So we ask ourselves some questions. Matters internal to ECCO. What does ECCO in real time and space look like now in 2025? Matters external to ECCO. What does the context for ECCO look like now? With respect to both questions, we need to ask what significant innovations, legislative, regulatory, policy changes have come along, what political changes have come along, what social changes have occurred since we last put our minds to ECCO, and which of these demands a reconsideration of ECCO. The A series and B series recommendations that you will find in the report when it's released are the outcomes of question 1. These recommendations are internal to the model. They update the model. A series recommendations by sector and B series across sector. And Christina will talk to you about those recommendations and the template that we follow in the report. C, D, and E series recommendations are the outcomes of question 2. These recommendations deal with matters external to the model to ensure that we have a broader context that is at least hospitable to the ECCO model. C series recommendations deal with the nursing crisis. D with recommendations for health system transformation, and recommendations under E deal with select determinants of health. I want to talk to you for a moment about the D series recommendations. That's health system transformation developments. There's a lot to say about all of the recommendations. One of the challenges that we have as a policy team is that each recommendation, not even each series of recommendations, is worthy of a report or two unto itself. But a few words about health system transformation, or HST, in particular, as the newest of the contextual factors that will impact the fortunes of the ECCO model. It rolled along very slowly through COVID, and more rapidly since, in the form not exclusively but mainly of iterative changes to the Connecting Care Act. That act was introduced in February of 2019 in the form of Bill 74. We have responded, I think, to every legislative change proposed to the Act and every regulatory posting, and you can find all those submissions on our policy web pages. Three significant developments worth noting. One is the government's focus on accelerating 12 OHTs to maturity. The second is the creation of Ontario Health at Home. Ontario Health at Home was established via the Convenient Care at Home Act as a single agency responsible for coordinating all home care services across the province. The Act, importantly, allows for the assignment of Ontario Health at Home care coordinators to work within OHTs and other frontline care settings, which has been a recommendation of ECCO through the ages. The setting of conditions for an OHT to enter into an accountability agreement with Ontario Health and to receive a single envelope of money to fund the OHT. That's the third major development with health system transformation. This is called designation. And designation requirements include creating a not-for-profit coordinating corporation for the OHT with specified characteristics to govern the OHT. They include establishing an advisory council of patients, families, and caregivers, with the chair of the advisory council serving on the coordinating corporation. They include establishing primary care networks within OHTs, and they include demonstrating home care delivery readiness. Each OHT must create and submit a plan describing how the OHT intends to provide integrated and coordinated services, as well as how the OHT plans to provide home care services. We had a lot to say about the criteria for designation. And you'll see some of that in the D-Series recommendations of ECCO, but you'll see more extensive critiques of those criteria, again, in our submissions on the website. We note, too, in the report that there have been policy developments that conflict with the way we'd like to see health system transformation develop. They stand in the way of implementing ECCO, and we cite as an example Bill 60, and the expansion of publicly funded but for-profit surgical clinics in Ontario. While our responses to legislation and regulation have the look and sound of health policy, it's important to understand, however, that health system transformation is grounded primarily in fiscal policy as an expenditure management initiative. And in the report, we review that genesis. And as we note in the report, from the outset, we see in health system transformation the opportunity to make the ECCO model a reality in Ontario. Yet we have always been mindful of and concerned about the competing government interests embedded in health system transformation from the outset. And those competing interests were expenditure management and a health system that was failing both patients and providers. So briefly, with respect to the fiscal policy angle, in 2018, the newly elected Progressive Conservative government noted that 90% of government expenditures were going out through more than 35,000 transfer payments to partners delivering government services. 42% of those payments were to healthcare partners. Quite legitimately, they could claim or complain that they had no way of knowing whether they were getting value for government expenditures. So HST is a response to that. It's about enabling management and control of expenditures and determining whether the government was getting good value for healthcare expenditures, keeping in mind that healthcare is responsible for about 40% of the provincial budget. The solution was and is to create one organization to manage the delivery of care in Ontario, and that's Ontario Health. That organization, in turn, is to fund a health system with just 58 transfer payments, not 15,000 anymore, and that's one payment to each OHT. Structured this way, the government will be able to assess which Ontario Health team provides the best value, dollars of care expenditure per capita, and determine the efficient price of health care in Ontario. So an obvious concern emerges to us as policy people: who and what services get left out as the government searches for that efficient price, i.e. as the government assesses which OHT can offer care at the best price and sets that price as the funding level for all OHTs. And this is why, in part, the principles of equity, diversity, and inclusion are woven into the very fabric of this report. We've seen the government reflexes that concern us already in the form of the recently Community Care Recovery Act. That is the new legislation that shuts down supervised consumption sites in Ontario and closes the door to harm reduction services. And so we have a number of recommendations in the report related to HST to ensure that the marginalized are included and have a voice, and that the funding formula for OHTs doesn't leave a door open for those who need care the most to get pushed out the first. So a few words about HST as health policy. HST was never without consideration of health outcomes. You recall the focus during the election of 2018 and in the early days of the Ford government was on hallway health care and the government's commitment to end it. So while Ernst & Young, a business consulting firm, was advising the government about how to bring expenditures under control, Ruben Devlin, author of the Premier's Council's reports on hallway healthcare, was advising on the efficiency and efficacy of integrated healthcare systems. HST as an expenditure management initiative and the corresponding loosening of regulations over the system, in theory at least, that it implies was anticipated by its architects to produce a substantial dividend in the form of better value for health expenditures. Expenditure management plus better outcomes equals better value was the formula. So as our ECCO report shows, however, health system transformation has yet to demonstrate that substantial dividend, and indeed, post-pandemic has a bigger challenge in front of it than when the legislation triggered this whole process back in 2019. The implementation of our ECCO model, too, in this post-pandemic world faces some enormous challenges. So I'm going to turn this over to Nasha first to continue this story with an overview of the key health system indicators, starting with that very important and interesting one, hallway healthcare. Nasha.
Good morning, everyone. My name is Nashia, and I'm a junior economist at RNAO. So first, can you hear me? Yeah, they can. Yes. No. Okay. Is it okay now? Yes. Okay. So I'll start with Okay. Okay, so I'll start with some key indicators that we'll see regarding a certain sector, that's hospital, primary care, community care, and home care. So we have seen that pandemic proved our health system precariously underfunded, misaligned, and fragile. And its adverse impacts are the consequence of decades of hospital-centric policy and the neglect of community care, which has undermined the functioning of our hospital sector. Now, as you can see, so we will look at certain indicators that represents that we have a deficit upstream in the system. So first, as you can see here, that the number of hallway healthcare patients increased at a higher rates post-pandemic. And if you look at the LLC cases over time, we can see that January last year, it reached highest, and it is significantly higher than the previous all years. And if we also focus on the emergency department, right now, the average length of stay is 20.4 hours, and pre-pandemic, it was on average 15.1 hours. So as you can see, this sector continues to be overwhelmed, even though hospital accounts for about 1/3 of the Ontario's healthcare budget. This suggests that health spending is distributed in the wrong proportion across sector. So now we will provide an overview of the current state of 3 core sectors that I mentioned before. And first we'll start with the primary care. In 2020, we had only 1.8 million people without a regular primary care provider, which increased to 2.5 over the course of the pandemic. And it is forecasted that by next year, there will be more than 4.4 million people. And among this group, households in the lowest income and households with the most racial diversity concentration have the highest unattachment rates. But that doesn't mean that those who have a regular primary provider are in a better place. As you can see, only 30% of the patients were able to get a same-day or next-day appointment with their primary care provider, and only 25.4% of patients had a follow-up with their primary care provider within 7 days of leaving hospital. If we look at the home care, we can also see there is an insufficiency to meet patients' needs. More than 25% of patients visited the ED within 30 days of release from hospital, and more than 13% of patients were readmitted to hospital within 30 days of the release. If you look at the home care, we can see an upward trend. If you look the left one, that there is an upward trend in the home care waitlist over the years. And right now, there are more than 45,000 residents are waiting for a bed. And the number is projected to increase over time owing to the aging population. And to the right, you can see that in recent years, the median number of wait days from in community setting increased compared to the pandemic and pre-pandemic levels. There is no doubt that the impacts of overburdening ER are due to the nursing scope of practice constraint and the nursing shortages across primary, home, and the long-term care. And the solution to reduce the ER visits from the long-term care residents is to expand the RN prescribing and to increase the prevalence of NPs in nursing homes. That's why the ECCO model points to the value of investing resources upstream to the community care. So it is clear that our system is struggling, and there is a significant gap between what our provinces has allocated and the need to fund the current health care programs and its program expansion commitments in hospitals, home care, and long-term care. The recent fall economic statement projects that there is an expenditure increase of just 0.6% in the current budget year and less than 3% increase over the subsequent budget years. And if we look at the public health, we can see the province is not doing enough. Ontario's contribution to the direct pandemic support measures were just 15%. And the Public Health Ontario found its base funding reduced to less than pre-pandemic levels. All of this suggests that the province will face significant challenges to meet the demand of Ontarians in the coming years if it does not increase its spending. And in addition to do that, we also need to think about the current healthcare trends and the projected demographic change. A study projected that by 2040, there will be 8.2 million people live with some or major illnesses. As you can see, that the incidence will be higher for the population age 65 and older. To resolve this issue, we need to have a strong partnership between public health and all sectors of the system, particularly primary care for early detection and management of the chronic conditions. And we also need to look further upstream to address social determinants of health, since there is a direct correlation to the risk of multimorbidity and household income. That is, the risk of multimorbidity increases with lower household income. We also need to think about the different socioeconomic subgroups, because we can see that income insecurity disproportionately affects marginalized population. So to reduce health inequities and for the longer sustainability of the health system, we also have to think about them as well. With that, we are done with our background discussion. Now we will move to our recommendations. So I welcome Cristina Polano to continue the presentation. Thank you so much.
Hello, everyone. Can you hear me okay? Yeah? Okay. Hi, everyone. I'm Christina, Senior Policy Analyst with the Policy Department. I've had my question picked out since Doris mentioned it, so maybe we'll open it up with a little bit of a trivia question about ECCO. I think one or two of my colleagues might have given it away, but let's see if you guys can get this one. So what is the specific role that ECCO envisions for RNs in primary care? And this has been since ECCO 1.0. Does anyone know? Yeah. What is the specific role that ECCO envisions for RNs in primary care? Alana's got the mic, so she'll see who had their hand up first.
Oh, I just about did my AGM intro. Paul Emanuel, Mississauga chapter. I'm going to go with RN prescribing.
That is a key competency, Paula, yes.
But I'm not going to get a prize. Is that what you're telling me?
It's right, and it's part of a broader role that we have envisioned. I'll give it to Paula because it's important and we've made big gains on RN prescribing, but it's care coordination, and we're going to talk a little bit about that in one of our upcoming recommendations. So, all right.
So just to be fair.
Yeah.
Just to be fair. Paul Andre was right, scope of practice. You were right, RN prescribing, and very specifically care coordination. Now let me ask a difficult one, which probably only very few people will know, and you cannot answer, and you may not know. What's the report, the first report of RNAO, and was not ECCO, that we wrote about RN prescribed? She knows, look at that. She also was a student, like the students here. She also was a student when she started with RNAO. The first report where we wrote about RN prescribing, what was that report? What was that report?
It is actually one of my favorite reports, Primary Solutions for Primary Care. So a lot of the recommendations that stemmed out of that report made its way into ECCO 1.0, particularly in relation to the role of primary care in the system, and most importantly, the role of RNs and NPs within primary care. So I love that report. I feel like the recommendations still stand today and it's so important. And I think Doris hinted that we might look at updating that one too one day because it's a really excellent, yes. Yeah, both were excellent answers. Sorry, I didn't hear you, Paul Andre, but that was an excellent answer too, scope of practice. All right. So with that, I'm going to be presenting on some of the ECCO 4.0 recommendations. And as Matt had mentioned, I'm going to outline a little bit of the template that we have for the actual report that you can expect to see. So when you read the report, you'll find the following structure for our recommendations. So first, the recommendation itself, which is the recommendation and then a couple of overarching statements about the recommendation. Then we have a list of accompanying action items related to the recommendation, which help to guide the implementation of the recommendation. We have an evidence-based rationale for each and every recommendation. We also provide this time around, and I think it's quite interesting, some promising interventions because there have been some pieces of progress and a lot of movement, especially at the organizational and local OHT level, that we consider worth highlighting so that we can show them as exemplars in the report and worthy pieces of initiatives to scale up at a grander scale. This time around, too, we also provide a specific section about government promises and progress. As Doris mentioned, this is a long-standing report ever since 2012 with multiple iterations. So we felt it was really important, especially in the context with a lot of different health system transformation changes. We wanted to provide some insight into where have we made progress? What are the current government promises in the recent years that have helped us move towards the ECCO model? And there have been some examples of that. And then we end each recommendation with a summary and next steps to kind of tie everything together and let the reader know, okay, this is where we need to go next. So all of that in a nutshell, for today's purposes and in light of time, we're going to be providing more of a high-level overview for our recommendations and action items specifically. But we did take the opportunity, wherever applicable, to pick out maybe one or two promising interventions or government promises in progress. So yes, a high-level overview of our recommendations and action items for today. So starting out, we're going to be starting with sectoral recommendations, and we'll look at key initiatives that must be implemented in community sectors to achieve the ECCO 4.0 model. Our first sectoral recommendation focuses on public health. As Nasha just mentioned, the importance of public health and a population health approach cannot be understated due to the projected patterns of demographic shifts and increased multimorbidity. Simply put, our current hospital-centric health system is not equipped to handle the increasing complex needs of our growing population. This is where leveraging public health comes in, so that we can take an upstream health promotion approach with early detection and proactive management. In an integrated health system, this means that we need to align public health with all sectors, and in particular with primary care. It also means that we must leverage the expertise of public health to implement population health approaches. This recommendation can be implemented by promoting and formalizing public health engagement in OHTs, including requiring public health presence on OHT boards, and establishing closer ties between primary care and public health through OHTs. We must also support public health to achieve its full capacity. For example, leveraging resources and expertise on preventing and postponing illnesses at a population scale. Public health must no longer be siloed. It needs to be recognized as an integral member of OHTs to reach its full potential and capacity. So one interesting example that we pointed out in the reports that leads to a population health approach is through the Guelph-Wellington OHT partners, who have adopted a health equity questionnaire, a tool designed to gather information about the social determinants of health, helping healthcare providers within the OHT to better understand their patients' unique challenges and deliver more personalized care that addresses these factors. Next up, we have our primary care recommendations, and we know that in the ECCO model, primary care serves as the anchor and entry point to the health system. We must therefore heavily prioritize expanding primary care to achieve better system integration and health outcomes. The first recommendation related to primary care has to do with universal reach. With over 2.5 million Ontarians uncertainly attached to primary care, and with many attached Ontarians lacking timely access to primary care, we need to improve primary care access. This must involve guaranteed attachment to a family doctor or NP, with 24/7 primary care options available to avoid unnecessary ER visits, for example. We also need to prioritize meaningful attachment to interprofessional primary care-based teams for all Ontarians. Valuable lessons can be drawn from countries such as Finland and Norway to improve primary care access in Ontario. Interprofessional teams are central to primary care delivery in each of these countries, with nurses fulfilling important and expanded roles. Finland and Norway, for example, have achieved nearly 100% attachment to primary care. Assignment to a primary care provider is automatic and often at the closest location to where people live, and after-hours care is highly organized. Nurses in these countries within the primary care sector are often the first point of contact and will provide an initial assessment, triage, and refer to the next appropriate level of care. To achieve this guaranteed access in Ontario, concrete action must be taken to grow the pool of primary care providers. New interprofessional primary care teams must be created, and existing ones must be further expanded. Primary care models that increase access and equity for equity-deserving groups must be prioritized. Models such as nurse practitioner-led clinics, community health centers, and AHACs, for example. And particular attention must be paid to leveraging NPs. This can be done by expanding the number of nurse practitioner-led clinics across Ontario and funding independent NP practice without user fees for situations where interprofessional teams are not available, for example, in smaller or rural communities. The government has made some promises over the past few years to expand primary care. Dr. Jane Philpott has been appointed by the Ontario government to lead a new primary care action team, which has a mandate to connect each person in Ontario to primary health care within the next 5 years. This plan will also strive for more convenient access and better service on things like weekends and after hours. And RNAO has been heavily involved in shaping this work. Another piece of government progress is that in January of 2025, the Ontario government announced $1.4 billion in new funding to connect 2 million more people to a publicly funded family doctor or primary care team within 4 years. We welcome these announcements, and we do hope that they bring us closer to achieving our ECCO model, but we stress the importance of implementing each of our action items that you see on screen and that you'll see even more in depth in the report. Our second primary care recommendation has to do with equitable access to primary care. It is very concerning that individuals from lower income quintiles and individuals from racialized and newcomer communities have worse attachment rates to primary care in Ontario. We know that many equity-deserving groups experience significant gaps in healthcare services in Ontario. To help to close these equity gaps, our primary care system must meet people where they are at, in the locations that they know and trust, and at the hours that they are available through expanded outreach and delivery of services. We must also ensure that community members are involved in shaping their care. Their lived experiences are crucial to design and develop appropriate interventions for health and for social services. We must prioritize the social and environmental determinants of health and integrate social interventions into primary care. A promising example is Northwestern Toronto OHT, which has implemented a community care hub with flexible hours, no need for a referral, and an accessible services co-designed with the community to meet and reflect local level needs. Another promising intervention is the Scarborough Centre for Healthy Communities in Toronto, who has launched a mobile health van for people who face challenges accessing traditional healthcare services or locations. Next, we get into our home care recommendations. It is clear that many of the issues that we're seeing across the health system that Nashia had just shared with us could be addressed by the home care sector. Many of the concerns in hospitals and in long-term care, such as hallway health care, ALC beds, emergency department wait times, and long-term care wait lists are a symptom of an underfunded and underutilized home care system. And the demand for home care is only going to increase, with a projected increase of 12.1% demand this year alone. Despite recent government investments in home and community care services, much more must be done to keep up with the growing demand for these services. This calls for increased access to more expansive and integrated home and community care services. An updated home care model must fund baskets of services to allow a person-centered approach that encompasses a range of nursing interventions, including health education, teaching, treatment, rehabilitation, health maintenance, social adaptation and integration, support for families and caregivers, and end-of-life and palliative care. Funding packages should be provided to expand access to home and community care services in equitable ways, according to individual needs. And OHTs must be encouraged to scale and support models of home care that facilitate integration between home care and other sectors. Some promising local examples include Southlake at Home, which is an innovative population-based program that interconnects the hospital, home and community care, and primary care by providing patients with an intensive transitional plan of care from the hospital to their home. The House Calls for Seniors program is another exemplar that we highlight. It's led by Sprint Senior Care, and it provides seniors that are frail and homebound with interdisciplinary care at home. Our next recommendations have to do with long-term care, and they have to do with increasing funding, resources, and integration of long-term care homes within the system. So we do have a long list of action items to optimize the long-term care sector in ECCO 4.0, but I'll just highlight some of the main key points for the purpose of time. So first and foremost, we are calling for mandatory inclusion of long-term care homes in both OHT configuration and decision-making structures, so that long-term care can play a bigger role in OHTs. We are asking for a person-centered long-term care model that incorporates residents' needs and wishes, integrates socio-demographic data, and better meets the needs of diverse resident populations. We continue to press for improved quality of care for residents by revising the funding formula to account for resident complexity and quality outcomes. And we also press for improved key performance indicator tracking within the long-term care sector. We also continue to push for the implementation of improved staffing measures in long-term care, which we've been talking about for quite some time, such as RNAO's Nursing Home Basic Care Guarantee staffing formula, as well as increased utilization of NPs and LTC, both as attending NPs and as clinical directors. We've also recently been calling for the establishment of a Dementia Care Center of Excellence led by RNAO to promote the delivery of evidence-based and compassionate care. Although there really is still a lot to do in long-term care, we have made some gains for long-term care in recent years. So some key examples include funding to hire 225 attending nurse practitioners, as well as most recently, the utilization of NPs as clinical directors in long-term care. Both measures will help to ensure that residents are able to receive high-quality care in place, avoiding the need for unnecessary hospital transfers, which is one of the indicators that Nashia had showed to us earlier. Our full suite of action items must ultimately be implemented to ensure that staffing, quality of care, and EDI are improved and evaluated in Ontario long-term care homes. So next up, we have our cross-sectoral recommendations, and they span across all sectors of the system. To achieve the ECCO model, person-centered approaches to care must be implemented across the health system to prioritize health promotion, disease prevention, and incorporate the principles of equity, diversity, inclusion, and community engagement. We know from RNAO's Person and Family-Centered Care Best Practice Guideline that there are several key strategies for providing person and family-centered care, which we highlight extensively in the report. In addition, all levels of the health system must be bolstered by approaches to care that integrate equity and community engagement. OHTs need information about upstream determinants of health within our communities, and they need to hear about people's lived experiences. This is crucial to design and develop appropriate interventions, responses, and resourcing specific to each OHT. To ensure proper incorporation of community perspectives, RNAO suggests mandating a seat for a community representative on the board of the coordinating corporation for each OHT. This inclusion will provide valuable insights to improve social and health service delivery. A promising example of person-centered care that we highlight in the report is from East Toronto Health Partners Ontario Health Team. This OHT partnered with RNAO's Best Practice Spotlight Organization BPSO program in 2019 and developed its first collaborative quality improvement plan in 2020 using the Person and Family Centered Care BPG. Partner organizations within the OHT adopted the shared focus to improve patient and caregiver involvement in care planning and treatment across various healthcare settings. East Toronto Health Partners involves patient and caregiver advisors in strategic planning, program design, and service design. The next recommendation is a central aspect of the ECCO model since its inception: comprehensive care coordination that is situated within primary care. Evidence shows that care coordination is a core function in high-performing primary care models. Primary care-based, RN-led care coordination is well supported within the scientific literature. We envision the purpose of care coordinators to be twofold: facilitating access to interprofessional and specialized care for patients, and improving system navigation by establishing consistent contacts for patients and families throughout their health system interactions. RNAO has long posited that nurses in primary care are ideally situated to act as care coordinators to improve access to timely, integrated, and appropriate primary care for Ontarians, and this remains a key recommendation in ECCO 4.0. Our next cross-sectoral recommendation is about implementing evidence-based practices across the health system. ECCO envisions the creation of an evidence-based culture within OHTs, driven at the local level. Significant local resources, supports, and best practices are available to health organizations to facilitate this. Some of the key resources we know include RNAO's Best Practice Guideline Program, or BPG, RNAO's Best Practice Spotlight Organization Program, including RNAO's BPSO OHT model, and RNAO's Nursing Quality Indicators for Reporting and Evaluation, or NQUIRE database. To fully realize the ECCO model and anchor the system in primary care, evidence-based planning and decision-making will also be paramount. By collecting rigorous evidence and utilizing it for planning purposes, this will help to ensure equitable distribution of services tailored to specific community needs. In the realm of digital health technologies, the ECCO model seeks to enhance access and integration across the health system, support person-centered care, and increase system efficiency. Collection and shared use of health data across settings through digital health technologies informs decisions and ensures accountability. The improved access to population health data and personal health information supports better integration and collaboration among health providers and among persons receiving care. Currently, no single longitudinal health record exists in Ontario nor in Canada. Health information is siloed across many systems, limiting provider access and causing duplication and delayed care, with negative implications on clinical decision-making. This gap creates barriers as patient health information spans the entire continuum of care. RNAO's ECCO model supports a standardized and shared system for collecting data and disseminating health information across the system. One promising exemplar that we highlight in our digital health section is RNAO's Clinical Pathways program, which embeds RNAO's BPGs in electronic medical records to standardize care, consistently measure outcomes, and ultimately optimize resident care experiences in long-term care homes. The next cross-sectoral recommendation is regarding scope of practice. The ECCO model promotes full scope of practice utilization for regulated health professionals, with particular emphasis on RNs and NPs. RNAO has long advocated for a workforce where RNs and NPs can make full use of their skills, experience, and education to provide timely access to quality, evidence-based, and person-centered care. To further leverage RN and NP scope, additional legislative and regulatory changes must be made. Organizational barriers must be removed, and targeted resources must be provided to power RNs and NPs to advance their knowledge, competencies, and skills. We have made several gains in recent years related to RN and NP scope expansion. So for RN scope, the Nursing Act was amended to allow RNs to complete additional training to prescribe specific medications and communicate related diagnoses. And recently, as announced in November of 2024, RN scope will be expanded to allow RNs to certify a death when the death is expected. And the Ontario Ministry of Health is seeking to integrate RN prescribing education into existing baccalaureate nursing programs. I know that Doris sent out a call for proposals. It was a huge win and evidence of effective RNAO advocacy. And in the ECCO report, we do highlight Carleton University's new direct entry full-time compressed BSCN program as an exemplar, which will integrate RN prescribing into its curriculum. Did you guys all hear that question? Which is the first program that will have the RN prescribing within its program? Carleton, who said it first? I'm not sure, it was either Una or Rob? Do we have enough for both? I think it was around one. Una?
Is the first program period in 25 years, and they will integrate baccalaureate, and there are more that will be announced that will integrate baccalaureate. And in the, oh, that's a good question for Madame Claudette, that will ask you, you can all prepare. When in the platform is RNAO asking that all the programs have baccalaureate in their curriculum, have RN prescribing in their curriculum? When? By which year? You can get ready for it. By which year? You can look at the platform in their website. It's there.
Does anyone know? Oh, we're gonna keep it for later? For Claudette later, okay, sorry. Okay, so I'm almost done. We're gonna talk a little bit about NP scope too. So there have also been many scope expansions over the past several years, including, for example, the ability to perform point of care tests and to order CT and MRI scans without contrast, just as a couple of examples. But we know that there is still so much more to do so that we can fully harness the potential of RNs and NPs. And that's why we continue to advocate for further scope expansions for both RNs and NPs, as you can see, based on our list of action items. Okay, so the final recommendation that I will share with you before passing it on to my colleagues will be regarding nursing careers in Ontario. This is a topic that RNAO has been pushing for several years, and so these recommendations will be familiar to many of you. The inclusion of this topic in ECCO 4.0 is paramount because we require adequate nursing recruitment and retention, especially in community sectors, to achieve the ECCO model. And we know that there are several statistics and metrics that demonstrate a nursing crisis in Ontario. Just one that I will point out today is that Ontario's RN per population ratio decreased in 2023 from 659 to 651 RNs per 100,000 population in Ontario, which is by far the lowest in Canada. In comparison, the rest of Canada is at 816 RNs for every 100,000 population. Additionally, we know that Ontario is nearly 26,000 RNs short of the rest of Canada on a per capita basis. And so our overarching recommendation is to enhance nursing retention and recruitment by improving working conditions, strengthening supports across all levels of the profession, and expanding Ontario's nursing workforce and student population. So you can see that there's a long list of action items on screen, and I know that they're going to be discussed very shortly today in the RNAO provincial platform, but I'll just press that, again, nursing retention and recruitment are paramount pieces of our ECCO model. And so with that, I will pass it over to my colleague, Nashia, and thank you so much for your time.
Hello again. Just give me a moment, sorry. So I'll start with the second part of this recommendation. And in line with the previous discussion, evidence shows that the compensation is a contributing factor to retention and recruitment across sectors. And we usually consider the owner hospital ER rate, RN hourly wage rate as a proxy for nurse wages, as the figure shows that nursing are earning less today than they did in 2010. And this is the case for the sector which is at the most advantage. We also deep down this year to look at compensation across sector, and this shows that there are significant disparities within the system, and regardless of the wage grade, home care sector RNs were at the most disadvantage. And despite the same level of education, home care RNs and primary care RNs on average earn 68 cents and 78 cents respectively for every dollar earned by hospital RNs. So hospital RNs usually got an average higher wage increase, but if you look at the community care sector, they usually got the lower wage increase. For instance, recently, home care RNs only received an increase of 3 and 4.6%. So this is clear that compensation inequities across health system will continue to undermine the health system transformation and perpetuate system misalignment. So it is imperative to harmonize compensation upward and increase compensation for nurses working in all roles, domains, and sectors. So now we will turn to focus on the recommendations related to the current health system transformation that was mentioned before. And so we will start with the funding model. So ministry envisioned that at maturity that there will be a prospective hybrid model of funding comprised of risk-adjusted capitation and bundle payment for specific episodic conditions. So to improve patient and the population health outcomes, an adequate and optimal amount of funding is required. At the same time, the funding model must ensure equity. To achieve these objectives, a verified count of the population is needed. But the current attributed population inclusion criteria that ministry focuses exclude individuals with no regular primary care provider, who did not seek primary care services in the last 3 years, and who have no designated postal codes. So it is crucial for the current estimation to include these individuals into their assigned population count. Besides, the funding model must ensure fair pricing. To better predict healthcare spending, OHTs must incorporate socioeconomic, clinical, and epidemiological indicators into their funding formula, because adjusting the formula for some specific indicator, for instance, age, is insufficient. And evidence shows that healthcare costs are highly dependent on individuals' race, immigration status, and their healthcare conditions. OHTs are also envisioned to integrate healthcare and social services into their delivery plan. And traditionally, there were separate budgets for these two sectors to make the integration successful and to foster an accountability between those two sectors. Pooled funding with a single governance structure is imperative. So with that, I'm done with the funding model. Now we'll move on to our next recommendation, which will be discussed by Julia. Thank you so much.
Good morning, everyone. It's great to have you here. My name is Julia. I'm the Nursing and Health Policy Analyst with a focus on determinants of health, and I will be continuing with more recommendations. Okay. Recommendation D1 is on primary care network. Our recommendation is OHTs should strengthen primary care leadership, coordination, and social service integration to improve patient care. And we have identified, as you can see on the slides, 4 action items. The first action item is to establish leadership roles for PCNs. Primary care networks, or PCNs, should be given a leadership role within each OHT to ensure that healthcare remains community-based and primary care and anchored in primary care. Second, ensure PCN representation on OHT boards. Each OHT's coordinating cooperation boards of directors should include 1 nurse practitioner and 1 physician to represent PCNs. Third, enhance care coordination in primary care, which my coworkers already stressed in their sections here again, and enhance care coordination in primary care. OHTs should embed care coordination and system navigation within primary care to improve patient experience and service delivery. Last, integrate social services into PCNs. OHTs should incorporate social services within PCNs to better address the social determinants of health and enhance patient care. Recommendation D2 is on mental health and addiction networks. We recommend engage mental health and addiction networks in OHT planning and decision making. And we have identified, And we have identified the following 3 action items. First, invest in an integrated substance use model of care across all healthcare settings, but allocating existing and, if required, additional funding from the road to wellness. Second, link provincial mental health and addiction priorities to local OHT development. Third, facilitate integration of mental health and addiction services across sectors with a particular focus on direct navigation from primary care to local or regional mental health and addiction services. And here we have highlighted some major challenges in mental health services, and many of you, sorry about that. It's not synchronized. Okay. My apologies. I only focus on that slide deck. So some major challenges in mental health services. I listed, highlight some major challenges here, and many of you will be familiar with, including cost barriers and financial distress, fragmented and poorly coordinated care, inequitable access, regional disparities, wide variety of providers, a mix of private, for-profit, and unregulated services, and inadequate funding. And here are some mental health outcomes in a data-driven perspective. In Ontario, the first data evidence is a nationwide data. So less than 50% Canadians with mental health concerns actually receive services. And 28,000 children on mental health wait list. And the wait time, this is in Ontario context. So in Ontario, this is from the Children's Mental Health Association. And this data was 2022. And in their report, they identified 28,000 children on the mental health wait list, and the wait time was up to 2.5 years. And with the pandemic proceeded, everyone, we're facing deteriorated mental health in general, and this worsening mental health amid and beyond the pandemic. And in 2024, actually, there were more than 73,000 children with autism spectrum disorder are seeking services, compared to this number in 2019 pre-pandemic was only 23,000, which was already significant. However, post-pandemic, this number just rise significantly. Oh, okay. Sorry about that. But all the data, they are self-explanatory, and I hope they make sense to you. And in 2023, psychological referral volumes really doubled compared to 2 years ago, 2021. And we have significant rise in drug toxicity deaths. RNAO has been making relentless effort in these areas through various channels, including social media and public health advocacy. We have been consistently raising awareness and calling on all sectors involved to take action to tackle toxic drug crisis. We're also developing a political action bulletin on this topic as well, providing an in-depth analysis and advocating for an integrated model of care for substance use. Now we're moving to determinants of health. Okay. Sorry about that. My notes are somehow all interconnected, similar to all the determinants of health. They are all interconnected and intersected. Thank you. Okay, I have to find my notes. Social determinants of health. Increase the fiscal effort to address the social determinants of health with focus on housing, food and income security, Ontario Works, and the Ontario Disability Support Program rates, ODSP rates. And due to the time constraint here, I can only talk about the housing as a social determinant of health. Thank you. And housing crisis, everyone is aware of that we're experiencing the housing crisis. One of the main contributors of the housing crisis is a severe shortage of social housing relative to the demand. This graphic clearly indicates that since the 1980s, the number of newly built social housing units has been decreasing year by year, as you can see, with from 1980s, from pre-1980s till right now, 2020 or later. Right now, yearly, newly built social housing units is only about 2,600 in Ontario. And let's look at in comparison, look at the demand of social housing. I don't know if you can see the columns. They represent the households with, how many households are on the social housing wait list. And the orange dots, they represent the wait list, the wait time. And Ontario and Toronto, they're in the middle, you can see. Ontario has 136,650 households on the social housing wait list. That's in Ontario. And the average wait time for social housing in Ontario is 62 months, which is 5 years. And in Toronto, it's more, this number is more dramatic. And Toronto almost makes up more than half of the Ontario's social housing demand. And the wait list in Toronto for social housing is up to 96 months, and which is 8 years, right? Yeah. So that's a demand for social housing. And compared to the previous slide, it's our social housing stock. And that's a major contributor of the housing crisis we have identified is the increased housing affordability. And in this graphic, I don't know if you can see there are 5 lines on this graphic. The highest one has a small 34 that represent the increased average rent in Ontario for a 2-bedroom apartment, for 2-bedroom housing. That's a rent increase. And then the next one is the increase of average hourly wage. And the next one, at the lower level, is the increase of minimum hourly wage. And then the blue color is the increased ODSP rate. And sadly, and the pink line actually represented 0 increase. That represents the increase of Ontario Works OW. So the last 2 lines, they represent, from this picture demonstrates our reality. On the one side, it's the skyrocketing rent increase, 34% since 2018. And on the other side is our income increase. You can't compare the income, it's incomparable to the rental increase. And sadly, the social welfare remains very, very low and 0 increase. So there's no increase, no change for Ontario Works, and very slight increase for ODSP recipients. That's a reality. And here is the outcome. One of the housing crisis, the severe manifestation of the house crisis is the surge in homelessness. This data is released by AMO, Association of Municipalities of Ontario, in 2020, in this year, January, but the data was for last year. So more than 80,000 Ontarians was known to be homeless in 2024, a number that has grown by more than 25% since 2022. And more than half of this population are chronically homeless, which is characterized by prolonged or repeated episodes. And sadly, nearly 1/4 of the chronically homeless population are children and youth. And here comes the EDI piece. So the housing crisis doesn't, just like other social determinants of health, they don't affect everyone at the same magnitude. Here we have listed some marginalized groups. The first one, indigenous people, and then Black people, 2S LGBTQI, and people with disabilities. And the lighter, the orange color at the bottom represent the percentage, their population, the percentage of this group among the Canadian population. So, and the top dark color, like a red color, means their representation within the homeless population. Let's look at the indigenous people group. Indigenous peoples only make up 5% of the total Canadian population. However, they represent 31% of the homelessness population. Similar situation also happened to racialized groups and gender minority and people with disabilities, just at a different magnitude. Here we are moving to recommendation E2, environmental determinants of health. Mitigate climate-related impacts and strengthen climate resilience and health equity by advancing a low-carbon economy, accelerating the clean energy transition, and ensure health system preparedness. So we have identified 5 action items, and they are low-carbon economy, clean energy transition, climate resilience, health system preparedness, and uphold the rights of indigenous peoples. Before I move to the details of all these action items, does any one of you ever wonder, as a nursing association, why we are so concerned about the environment and climate change? Anyone wants to share some insights why we nurses care about the environment, talking about all these actions here? That's very true. Thank you. I hear you. Thank you for your answer.
We have an answer right here.
It's the largest global health threat to everybody, climate.
That's correct. Because in nursing, we also care about not all our individual health, also globally our environment, our mother nature, because the environmental factors affect us both physically, mentally, for our everyday life, and our both physical and mental health and well-being. And sorry, Doris, do you have a question? Elena?
No, she's okay.
Or do you have a comment? Do you want keep? Yeah, go ahead. Mm-hmm.
Thank you. I come from Northern Ontario, and we have communities that only have access by ice roads. Open 3 weeks of a year. The rest of the time, they come by plane, by boat, and the environment really affects the community care that can be given. because if they come out, they have to go back in. How do they go back in? So that's what I want to bring to you, that the environment really affects Northern Ontario. Thank you.
Thank you so much. I didn't talk to you before this presentation, but what you are saying really resonates this slide. I'm so happy. It just like it so happened this slide is here to reflect what you are saying. So this slide, you know, many of you, it's not hard. You can tell it's a map. It's a map of Canada. And I don't know if you can see the script on the top. It says temperature departures from the 1961 to 1990 average. Like this is the temperature departures actually from, they recorded this one in winter 2023 to 24. So not this winter we are experiencing, it's a last winter. So last winter in Canada, the temperature departures are captured here. And temperature departure, I don't know, it's not everyday language. And it just means the increase. As you can see, the blue color, like the cold color, means the temperatures are compared to the average of the previous, from 1960s to 90s, the average at that time, the temperature has been consistently, you can see across Canada, they're rising. We don't have any blue color or purple color here. We see some yellow, some orange, some dark color, and you can see Northern Ontario. So this map actually conducts two key messages. The first one is in Canada, like we are all facing this climate change, and last year the winter temperature, we have these kind of hot spots compared to from the 60s to 90s. And another message is that, I don't know if you can tell, the darkest color, actually, the largest darkest color is in Northern Ontario, like our member just brought up. It's in Northern Ontario, like although Ontario is experiencing these kind of unusual warm winters, but Northern Ontario experience increased, like the magnitude in Northern Ontario, like the increase range is much higher than than the Southern Ontario. So here comes the EDI piece as well, and for people and for the large Indigenous communities who locate in Northern Ontario, their life and their health are impacted most significantly than other population. And like our member just brought up, and Indigenous community have a closer connection to nature, to our environment in terms of food source, their gatherings and some ritual activities. They're all very close connected with nature. With the same kind of temperature or even crazier temperature rising up north, the impact on Indigenous people are disproportionate.
Hi, it's Sarah from Lakehead Chapter, which is in Northwestern Ontario.
Yeah.
So it's not only that, but I do want to say that the weather, what it does is it impacts our remote communities, the ones that you cannot just drive to. They need the winter rivers in order to freeze and become then the paths that you can bring food,
That's right.
supplies. When the weather changes, it impacts flights. The fly-in communities cannot get food, supplies. So the fluctuation in weather, yes, it impacts other aspects of health, but you really have to think we're here roads can access to health and things like that, it really does become impacted. And I do also really want to say that even in Thunder Bay, and we're the biggest city in Northwestern Ontario, we had a green winter last year. Not this one that just passed, but the year before. And so, yes, we are absolutely feeling the frigid colds and the very warm, weird winters. So, yes, thanks.
Thank you so much, Sarah.
I would actually like
well.
Sarah Sarah, can you come back? Just 1 minute. Yeah, no. Sarah, what are the roads called getting to those remote First Nations communities? What are those roads called that get to those remote First Nations communities? Ice roads? Yeah, what are they called? Like ice roads?
Ice roads, winter roads is what we typically call.
Yes, let's talk about ice roads and supplies.
Okay, very quickly, I'm from Sioux Lookout, Ontario. So just so you understand the ice roads, if you're going from Sioux Lookout, say, to Round Lake, it's like a 13-hour drive. There is nothing in between. There's muskeg, and I personally have not been on them, and I wouldn't want to, but you have to bring enough gas to last you 13 hours. So when there's a very short winter road season, like last year, I think it was end of January or something, and that's how they get their fuel. So you think of a fuel truck bringing oil, and they're bringing them on these ice roads. You have to go very slow. When there's muskeg, there's risk. And so the cost of driving a truck up there is one thing. The cost of having to fly fuel.
Yes.
And there's several, I should know this, but I don't, exactly how many Northern Reserves have just got hooked up to hydro. They were using generator power. So they had to need fuel for their generators. So getting hydro, like we're in Canada, and they don't have hydro. So I think we don't understand
Infrastructure.
just the impact of these warm, I mean, it's great. I love the warm winter, but the impact on the north is way more severe than we can really imagine. So just quickly.
Thank you. Thank you. I didn't expect the environmental determinants have got so much attention. When I was preparing and the slides, I thought maybe like one of my family members, one time they asked me, as Nursing Association, why do you guys care about so much about the environment? I had to educate them. I'm so happy you guys. Okay, thank you so much. And yes, my last slide actually here, basically I just want, here's the EDI piece as well, like within this climate change and the increased food insecurity disproportionately affect vulnerable populations, and also the not just the Northern Ontario for Indigenous population, vulnerable population also include seniors. For example, during the heat wave in 2022, when nationwide studied the 250 people who passed away due to the heat wave, like attributed to the heat wave. So this about 250 people died through the heat wave, and all of them are over the age of 65. So seniors are also disproportionately affected by climate change. And we have more on the slides, but because of time constraint, I won't be able to go to the details. And I just want to because I'm the last one from our policy group, I just want to close it this way. If we think if I use a metaphor to describe our over 100-page ECCO 4.0 report as a movie, then today's presentation is like its trailer part. We hope this trailer part gives you a sense of what's to come, sparks your interest, like the environmental piece, and leaves you looking forward to its full release. Thank you very much. Okay.
Well done for all the policy colleagues. I think the linkages that the team made, especially between the two foundational new aspects that we are bringing to ECCO 4.0, which are, what are the two new foundational pieces? Sorry? Climate and social determinants, and the other? That was from ECCO 1.0. That was from when we were born. Okay, EDI. Remember, two new foundational aspects to ECCO 4.0. Social determinants and environmental determinants, and also EDI. And the linkages that you made between those and access are critical. And of course, I always, when we discuss more, I have one more question, which is that we have looked very much at the increase, unfortunately, of unattached people to primary care. So this is for Christina and Nasha. And I think we need to look at two things very quickly before we finish the report. One is the weighted case versus population growth, right? Because population has grown in all these years. And the second is the disproportionate impact on any population that is disadvantaged. Not only EDI, but as you also said, EDI and older people, in terms of unattached, because that links to where we want to go with ECCO next. What we will do, so this is kind of what we call soft release. In about a month, you will see the report out. We will want you to go and advocate using the report and the recommendations, whatever is important for where you live. And you just heard some of the colleagues that spoke very eloquently here. So, and for others, maybe a different focus. And the second will be the platforms, which we will talk after lunch. Okay, so those we will be addressing in terms of advocacy. What is very, very important is where we are going next with ECCO, which is we are going to do separate in-depth papers instead of PUB and PIBs. We will do separate pieces that I am not sure how we will call them. On primary care, we will do another one on not-for-profit delivery or for-profit delivery. And we will do probably also home care and mental health linked to primary care and to public health, because it's also in schools. So we will see a lot more on that. Why? Because you will hear after lunch where we are going post-election and what we think will happen.